There is an ancient parable about 10 blind men who come upon an elephant. One touches the elephant's leg and says, "An elephant is a tree trunk." Another finds himself under the elephant's stomach, pushes up and says, No, an elephant is like a soft ceiling." A third pulls on the elephant's tail and says, "You're both wrong. It's a rope connected to a tree." All of the others report their own perceptions and conclusions, all completely different. Of course, all of them were right and also wrong. They all came to different conclusions because each of them had limited information. No one saw the whole elephant. Similarly, there's a wide range of misunderstanding about chronic pelvic pain for both patients and the doctors who treat them. With the benefit of 25 years of treating several thousand pelvic pain sufferers, we've gained fundamental insights into this condition. One of the major insights, which I will discuss here, is that whether someone has pelvic pain and has symptoms that are either sitting pain, rectal pain, genital pain, pain above the pubic bone, urinary frequency and urgency, pain with sex, pain on one side of the pelvis or the other, or pain in the middle, whether the pain moves from one place to another, and other symptoms, the common thread for all of these symptoms is a sore and knotted up pelvis. Skillfully press inside and outside the pelvic floor of the pelvic pain sufferer, and you will find pain does not exist with someone who does not have pelvic pain. The sore, knotted up pelvis and its related trigger points are what need to be addressed for the possibility of the pain going away, wherever it is felt, and the symptoms resolving. Let me explain it this way. Imagine 100 people holding one of their hands in a fist for a month with no break are asked about their condition after a month. Your hand would be painful if you did this. It would not be surprising if some of this group of 100 develop pain in the thumb, some of this group develop pain in the little finger, and others in the palm or the forearm. Apparently different symptoms of pain location, but the same cause, which is a hand that has been held in a fist for a long time. You wouldn't fundamentally treat this problem of a sore hand differently if someone had a sore thumb or a sore pinky. You may work with the thumb or the pinky locally to loosen and relieve the particular tissue contraction and pain in those parts of the hand, but the most important treatment would be to unclench the fist and attend to the sore hand to restore its relaxation and ease, whether the soreness is felt in the finger or the thumb. So it is with the varied and seemingly unrelated symptoms of pelvic floor pain. Whether someone has urinary frequency or urgency, pain with sitting, perineal pain, pain with sex, pain after a bowel movement, pain during or after urination, pain on one side or another, all of these apparently different symptoms originate from a chronically tightened pelvic floor and then perpetuated by the pain, anxiety, and guarding that follows. The different pelvic symptoms typically are related to the location of trigger points that form in the pelvis when the pelvis is held tight for a long period of time. Urinary frequency might be thought of as a painful thumb in the clenched fist metaphor, while pain in the pelvis while sitting or sex may be thought of as pain in the little finger. We have found that specific trigger points within the pelvic floor are related to specific symptoms. We originally published this in 2009 in the Journal of Urology. It turns out that various medical specialists treat the same condition of a chronically clenched pelvis, but they give this condition different names based on the specific symptoms I have just listed. For example, gastroenterologists and colorectal surgeons typically treat patients with posterior or rear pelvic pain symptoms such as anorectal pain, post-bowel movement pain, tailbone pain, anal fissures. Urologists treat patients with anterior or front symptoms, including urinary frequency and urgency, genital pain, testicular pain, painful sex, sexual dysfunction. Gynecologists treat genital pain and pain with sex, and so on. Again, my point here is that whether one is having genital pain or urinary frequency or tailbone and anorectal pain, these symptoms all derive from a chronically tightened pelvis. The only difference in these symptoms is where the pain is felt and the specific trigger points that are related to the symptoms. All the different names for pelvic pain, prostatitis, chronic pelvic pain syndrome, pelvic floor dysfunction, dyspareunia, levator ani syndrome, pudendal neuralgia, anal fissures, chronic proctalgia, are all essentially the same condition, even though they're treated by different specialists and often given different names. This is confusing to the patient, and I think it's also confusing to many doctors. What is of interest is that different symptoms tend to be related to the different locations of the trigger points inside the pelvic floor and outside the pelvic floor. In other words, whether someone has anterior or front symptoms, posterior or back symptoms, or both, their condition has produced trigger points in related anterior, posterior, or anterior and posterior locations. This is an important fact for our therapists clinically in locating the offending trigger points and drawing a map of the trigger points that the patient must work on in using our internal trigger point wand and our trigger point genie. While the symptoms may make it seem like the patient suffering from sitting pain has a different problem than the patient suffering from urinary frequency and urgency, the problem is the same, and the treatment for both of these symptom complexes is essentially the same. Pelvic pain is invisible, and the best diagnostic tool is an educated finger and experience in treating pelvic floor dysfunction. It is difficult for most medical professionals to detect the cause of pelvic pain because there's no objective test for it. It doesn't show up in x-rays or MRIs. The way we make the diagnosis for pelvic floor-related pain we treat is for a skilled specialist to palpate the tissue inside and outside the pelvic floor. We make the diagnosis of pelvic floor-related pain when we discover trigger points and areas of restriction upon palpation in and around the pelvic floor. We typically recreate or intensify a patient's symptoms when we press in certain areas, and we consider it diagnostic when we are able to recreate or intensify someone's pelvic pain symptoms upon palpation. In a paper we published in the Gold Journal of Urology recently, we explained that pelvic floor pain, in fact, is a psychoneuromuscular disorder. Given that it's the same disorder whether symptoms are experienced in the front or back or both, the diagnostic terms used for these symptoms by different doctors can be confusing because the irritated hypertonic pelvis can create the same variety of symptoms. These symptoms are genital pain in men and women, testicular pain in men, urinary frequency and urgency, hesitancy, post-urinary dribbling, waking up at night to go to the bathroom often, or painful urination, suprapubic pain or pain above the pubic bone, painful intercourse, post-orgasm or post-ejaculatory pain, anal sphincter pain, posterior perineal pain, anal fissures, pain with sitting, tailbone pain, low back pain. The wide variety of symptoms people complain about and the different diagnoses given to these symptoms when the cause of the symptoms is the same is why we named our book A Headache in the Pelvis. The Wise-Anderson protocol we first worked with at Stanford for treating pelvic floor pain and dysfunction is what we use whether symptoms are felt in the front, in the back, or in the front and the back of the pelvis.